This is Lynn McGrath presenting on endoscopic approaches for spinal procedures by Christoph Hofstetter and Lynn McGrath. As part of this presentation, our goal is for you to understand some of the basics of the history and development of endoscopic approaches to the spine, to understand the basics of how to handle the endoscope, and to identify and work through the major steps of an endoscopic discectomy. The word endoscope comes from two Greek root words. First, endon, which means inside, and two, scopine, which means to observe. Endoscopy, therefore, is the use of a thin, tubular, and coaxial surgical instrument that contains image transmission, illumination, and irrigation with a working channel. The beginnings of full endoscopic spine surgery date back to the early 1970s, when transforaminal endoscopic spine surgery was developed as an evolution of needle-based percutaneous endoscopic discectomy. A technique for fluoroscopic guided percutaneous non-visualized discectomy under local anesthesia was described by Parvis Cambin in 1973. These early intradiscal techniques allowed for resection of the posterior one-third of the nuclear pulposus and, in certain types of disc herniations, indirect decompression of neural elements. Cambin and colleagues reported an 87% success rate in a prospective series of 100 patients with symptomatic lumbar herniations. Cambin conducted numerous cadaveric studies to describe the boundaries of a safe working zone for posterior lateral access to the disc space. This became known as Cambin's triangle, and it's a theoretical triangle for safe access into the disc over the posterolateral disc. The hypotenuse of the triangle is the exiting nerve root, the base is the superior border of the caudal vertebra, and the height is the dura of the traversing nerve root. Much of the progress that has enabled widespread adoption of endoscopic spine surgery comes down to advancements of the working channel endoscope itself. The working channel endoscope contains an optical system and conduit for illumination which are sealed within a rigid tube. The gross majority of spinal working channel endoscopes use a rod lens system as an optical system. The angle of view can vary from 15 to 45 degrees depending on the type of endoscope. The optical system is located behind the working channel in the posterior aspect of the endoscopic shaft. The working channel allows passage of specialized endoscopic tools to the operative field. Pretty much any tool that can be used in open or traditional MIS tubular surgery can be adapted to fit through the endoscope. The length and diameter of the working channel lengths of the working channel limits the size of the instruments being used. So typically the instruments that are used are smaller than those in traditional or MIS approaches. Here we outline some of the key differences between the microscope and the endoscope. As you can see, the endoscope has a much closer working distance, 3 millimeters from the target. The field of view is much wider. You have a panoramic viewing field of the target pathology. It's also got a different line of sight. Instead of looking straight onto the pathology, you're working at a 15 to 30 degree off axis. The image is two-dimensional rather than three-dimensional. Instruments are all specialized to use with the endoscope, and of note, retraction is afforded by both the tube that is advanced into the working field, but also irrigation fluid, which constantly works to push the anatomy away from you and which can help to prevent CSF leaks, dural tears, things like that. The working corridor consists of a single working channel, as you can see in the diagram. Some of the differences highlighted on the previous slide are what make an endoscope an ideal tool for performing an ipsilateral recess decompression. The endoscope allows for decompression and direct visualization of the ipsilateral traversing nerve root due to the fact that it affords panoramic visualization, an off-axis visualization, and the fact that it has a very narrow tubular retractor, totaling between 7 and 10 millimeters. As a result, the endoscope can be advanced into the working field. It can slip along the bony resection down to the level of the nerve root, which you can see in the bottom right picture is directly visualized. The camera can then be turned around, and the off-axis visualization can be used to follow the nerve root as it exits. We can also see why the endoscope is the ideal tool for performing an over-the-top contralateral lateral recess decompression. The fact that the continuous irrigation helps to retract the thecal sac facilitates advancement of the endoscope contralaterally. The side-biting burrs also help to protect the thecal sac while maximizing drilling of the target pathology. And once again, the panoramic field of view and illumination and the fact that the camera is 3 millimeters from the target pathology helps to visualize the work that's being done. The endoscope itself travels through a tubular retractor. Specialized tubular retractors exist for interlaminar and transforaminal applications, and they serve the following functions. First, to protect the operative field from tissue creep, to prevent tissue from encroaching upon the view of the surgeon. The bevel at the tip of the retractor can act as an elevator and as a retractor. This can be used to sweep tissue away, to hold sensitive structures away from the operative field, and also as a dissection instrument. The bevel can also be used to retract neural structures such as the thecal sac or the nerve roots in order to advance beyond them to deal with pathology sitting beyond those neural structures. The two workhorse endoscopic approaches are the interlaminar and the transforaminal approaches. And here we'll talk a little bit about the differences between the two. The endoscopic transforaminal approach utilizes a surgical corridor via the inferior aspect of the intervertebral foramen, targeting the medial aspect of the foraminal annular window, Camden's triangle. The endoscopic transforaminal approach allows for treatment of soft disc pathology located in the foramen or in the lateral recess ventral to the traversing nerve root. This approach allows for resection of foraminal, subarticular, and central disc herniations. This is just a general overview of what the transforaminal approach looks like. The endoscope is held with a pistol grip, and the tubular retractor is controlled using the index finger as displayed in the picture to the left. The interlaminar endoscopic approach provides access to the ipsilateral lateral recess. This approach utilizes a traditional posterior interlaminar surgical corridor similar to minimally invasive tubular surgeries. Thus, the neural elements are encountered first, and the risk of injury is minimal. At L5-S1, typically no or minimal bone resection is necessary to gain access to the ipsilateral lateral recess. In lumbar segments above L5-S1, partial removal and or undercutting of the lamina and medial aspect of the facet joint is generally required to gain access to the ipsilateral recess. The need for bone removal is typically less with endoscopic technique compared to minimally invasive tubular surgery, since the endoscope provides off-axis panoramic visualization and can therefore look around corners rather than requiring a straight line of sight. However, removal of extensive osteophytes and overhanging bone in cases of scoliosis or spondylolisthesis may be time-consuming. Precise planning of the approach angle and meticulous attention to anatomical landmarks help to maintain an efficient surgical workflow and to minimize the need for bone removal. The interlaminar endoscopic approach is well suited for spinal pathology, especially at L5-S1. Lateral recess stenosis and synovial cysts at every level are additional indications for this approach. The interlaminar approach constitutes the foundation for the unilateral laminotomy for bilateral decompression technique and can be used as well for contralateral foraminal decompression. Here you can see the patient is in the prone position with the surgeon holding the endoscope perpendicular to the floor and to the patient's back. The endoscope rests in a C that's formed between the surgeon's thumb and index finger, and the tubular retractor is controlled with the index finger as demonstrated. The best way to illustrate some of the concepts that we've just discussed are to go through a case. So we'll go through a very typical example of one of the best use cases for an endoscopic approach to the spine. Here we have a 33-year-old male surgical resident who presented to us with 1 week of new left lower extremity pain and weakness. The pain came on suddenly after sneezing and radiated from the buttocks to the lateral aspect of the foot. It improved with standing and exercise, was exacerbated with sitting and flexion. He also had 3 out of 5 strength on dorsiflexion and in his EHL, and a loss of ankle deep tendon reflexes. Of note, he had a 2-year history of known low back pain. On his preoperative imaging, you can see clearly here a large disc herniation at L5, S1 with some superior migration and what looks like an independent fragment. Again, on the axial cuts here, you can see that the spinal canal has been almost totally obliterated by a very large disc herniation, taking up far more than 50% of the cross-section of the spinal canal. It's left eccentric, and it occurs across multiple slices. So in short, this patient presented to us with a large left paracentral L5 S1 disc fragment with rostral migration and impingement of the exiting L5 and traversing S1 nerve roots. Due to the fact that he was a surgical trainee, this made his job impossible to perform. We felt the large fragment was unlikely to resorb spontaneously on a timeline that he was comfortable with, and we felt that the best way to preserve motor function in his lower extremity was to offer a surgical intervention up front. So we decided to offer this patient an interlaminar endoscopic L5 S1 discectomy. Why did we choose the interlaminar approach? Well, it's because the interlaminar approach was developed specifically to provide endoscopic access to the L5 S1 disc space. The transforaminal approach is difficult at this level due to the fact that there's a large L5 transverse process and an iliac crest, which preclude typically an ideal trajectory during the transforaminal approach. The large caudally migrated fragment is also something that we like to use the endoscopic approach for, particularly the interlaminar approach, as we feel the panoramic visualization allows us to guarantee visually that we've taken out every piece of the herniated disc. And the fact that this is a surgical trainee who put a premium on getting back to work as soon as possible made us want to offer the most minimally invasive option possible. The less tissue damage, the less anesthesia, the shorter the hospital stay, the quicker he'd be able to turn to work. And that is something that has been demonstrated in the literature to be quicker with the endoscopic approach. This diagram demonstrates the wide variety of trajectories that can be taken with the interlaminar approach, both in the axial and in the sagittal planes. This also demonstrates, especially the sagittal plane, why we feel this is a good approach for approaching a L5 S1 disc herniation with rostral migration. One of the key steps before surgery is to identify the ideal trajectory for your endoscope. The way that we do this is by drawing a line parallel to the inferior end plate of the superior vertebral body. We then find a 15-degree angle below that, and this will be the desired trajectory of our endoscope. This angle provides the surgeon the optimum view of the disc space while minimizing laminar drilling. Once in the OR, we position our patient prone on a Jackson table with the Wilson frame expanded. We confirm our level on a lateral, and we plan a 1 centimeter incision off midline at the level that allows for that previously identified superiorly directed 15-degree angle of attack. We then switch to an AP and drop the X-ray tube about 15 degrees for a view orthogonal to the interlaminar space. We make a 1 centimeter incision with a number 11 blade, and we advance the dilator onto the inferior lip of the L5 lamina. We match the trajectory of the dilator to the trajectory of the X-ray tube in order to maintain the desired approach angle. We then place a working cannula over the dilator. We orient the blade medially in order to sweep aside encroaching soft tissue, and we palpate, in this case, the inferior lip of the L5 lamina with the blade of the cannula. After the cannula has been placed at the desired landmark, the inferior lip of the superior lamina, we advance the endoscope through it and clear aside soft tissue using a combination of the microrongeur and electrocautery. We remove all encroaching muscle until the L5 inferior lamina and the L5S1 facet are reliably visualized. Next, we perform a hemilaminotomy. We remove the inferior L5 lamina as necessary. Usually just a mild amount of drilling is sufficient, although we may need to undercut the medial aspect of the facet to obtain access lateral enough to medialize the nerve root and visualize the disc herniation beyond. To do all this, we use a high-speed 4mm diamond drill bit and a kerrison in alternating fashion. We drill off the lamina until the interface with the yellow ligament becomes readily apparent. Once we identify the interface with the ligament inflavum, we advance the endoscope in and we take the kerrison in order to take bites of the yellow ligament. We advance the endoscope right up so they can visualize the tip of the kerrison throughout each bite to ensure that no CSF leak is caused. We continue this process until the epidural space is readily visualized. At this point, we identify the nerve roots and the disc fragment. We expand the epidural exposure until the traversing and the exiting nerve roots are identified, and then we mobilize the nerve roots medially in order to identify the disc fragment beyond. Once the disc fragment is identified, we open the annulus with a micro punch. We deliver fragments until the affected nerve root is appropriately decompressed, and we look for healthy pulsations of the nerve root as a sign of decompression. Once done, we inspect the exiting and traversing nerve roots throughout their course for remaining areas of impingement. One should always check the axilla and the shoulder of the nerve roots for hidden fragments. Once the disc space has been sufficiently decompressed and all independent fragments have been identified and removed, the surgeon turns his attention to hemostasis and closure. We coagulate the disc resection bed and ensure further hemostasis with thrombin and coagulation where necessary. For closure, we close the fascia and the skin with absorbable sutures. And in this case, as soon as the patient woke up, he experienced immediate resolution of his leg pain, immediate resolution of his low back pain, and immediate partial improvement in strength. He had 4+ out of 5 strength in the left TA with continued gains in function over the next few weeks to months through physical therapy and rehab. In his case, and in most cases, no postoperative imaging is indicated. So in summary, this case illustrates a lumbar discectomy utilizing the interlaminar endoscopic technique. The major teaching points we hope you took away from this are the preoperative planning, the intraoperative steps, and the keys to an optimal patient outcome. Some of the pros and pitfalls for performing a successful interlaminar endoscopic approach are first to determine the approach trajectory before you go into the OR. Utilize a pre-op imaging, the MRI and the CT, to visualize the location of the disc and the interlaminar corridor through which you will gain access to the disc space, while accounting for any migration of the disc. A suboptimal trajectory will require excessive bone removal and an awkward working angle. Next, finding bony landmarks is key to navigation. The inferior lip of the lamina and the medial facet are key landmarks. Use the cannula blade as a retractor in order to identify bony anatomy, and remove soft tissue as necessary to always have bony anatomy as a ready landmark. Next, wide exposure of the epidural space. You need to remove sufficient yellow ligament in order to visualize the epidural space widely. This is critical in order to mobilize the nerve root medially for discectomy. And finally, close inspection of the nerve root. The main advantage of the endoscopic approach is visualization. The panoramic field of view that the surgeon has at the target pathology should be used to inspect the thecal sac and each nerve root to ensure complete decompression. In summary, we'd like to say that endoscopic spine surgery consists of a wide variety of techniques which involve approach corridors, anatomic perspectives, and specialized equipment with no equivalent in the world of open or MIS surgical techniques. Regardless of the unique characteristics of endoscopic spine surgery, the same fundamental principles that facilitate safe and efficient execution of traditional surgical approaches are generalizable and likewise essential to the adoption of endoscopic techniques. We hope this presentation was useful, and we hope that you'll be more likely, as a result, to incorporate endoscopic techniques into your practice. Thank you very much for your attention.